Welcome to Dr. Balaga's God Knowledge Doc podcast, your quick dive into the latest medical breakthroughs to keep you ahead of the curve. Let's get started. Today is September 4, 2025. This video is on a JAMA article published August 31st, 2025, titled Long-Term Anticoagulation Discontinuation After Catheter Ablation for Atrial Fibrillation, the ALONEAF randomized clinical trial. The accompanying editorial titled Lifelong Anticoagulation After AFib Ablation, Time to Reconsider. Catheter ablation is effective in restoring sinus rhythm in atrial fibrillation, yet guidelines recommend continued oral anticoagulation due to thromboembolic risk. ALONEAF trial tested if stopping oral anticoagulant post-ablation in low-burden AFib patients is superior to continuing it. 840 adults were enrolled, mean age 64 years, 24.9% women, randomized 1:1, discontinue versus continue oral anticoagulants. Follow-up 2 years. Patients had one non-sex related CHADS2 VASC stroke risk factor and no recurrence of atrial arrhythmia for greater than 1 year post-ablation. Statistics: Kaplan-Meier survival analysis, intention to treat per protocol analysis, subgroup analysis for age, gender, and AFib type. Results and takeaways: primary outcome, stroke, systemic embolism, major bleeding, 0.3% in the discontinued group versus 2.2% in the continued oral anticoagulants group, p-value 0.02, ischemic stroke 0.3% versus 0.8%, major bleeding 0% versus 1.4%, favoring discontinuation of oral anticoagulants. No all-cause mortality or myocardial infarction reported in either group. Limitations: open-label design, low event rates, and predominantly East Asian cohort. Key takeaway: discontinuing oral anticoagulants in carefully selected post-ablation patients reduced bleeding without increasing stroke risk. Clinical pearls: stroke risk post-ablation may be overestimated by CHADS2 DS2 VASC in absence of AFib recurrence. DOACs, direct oral anticoagulants, still carry bleeding risk even with careful dose reduction. Structured rhythm monitoring is vital before stopping oral anticoagulants. Majority of strokes in AF occur in those with recurrence of AFib, underscoring the need for monitoring. ALONEAF suggests a paradigm shift towards personalized anticoagulation post-AFib ablation. Editorial critique: historical precedent of firm trials showed paradoxical stroke risk when anticoagulation was stopped in sinus rhythm. The critique: ALONEAF used intermittent monitoring, undetected asymptomatic AFib, which could still cause embolic events. The editorial takeaway: patients with low stroke risk and high bleeding risk might benefit from discontinuation of oral anticoagulants. Subgroups not addressed: patients with extensive left atrial ablation or those above age of 80 years were not included. Limits generalizability: shared decision making, essential in weighing risks, especially when patient lifestyle or bleeding risk is a concern. Eponyms related to this paper: CHADS DS2 VASC score developed by Lip et al., an extension of CHADS2 score to improve stroke risk stratification. The Hasbett score introduced by Pistel et al. This score estimates 1 year risk of major bleeding in patients on anticoagulation. The Cockcroft-Gault formula estimates creatinine clearance for dose adjustment of DOACs, first described in 1976. The Kaplan-Meier method is a non-parametric statistic used to estimate survival function. And the Consor statement, standardized reporting guideline for randomized trials. If you enjoyed this episode, share it with your colleagues. When we change how we see disease, we change how we shape lives. Until next time, stay curious, stay compassionate, and keep seeking wisdom. Podcast brought to you by Master MedFacts at mastermedfacts.com.